Welcome, everyone. Welcome to the Behavioral Health Echo Series. This is a training session brought to you by the Center for Substance Use Training and Telementoring CSTED, a division of the Be Well Institute here at UT Health San Antonio. And before we start, I wanted to thank all of you first off for being here today and for supporting our series. Your consistency and your attendance and your feedback and your support is what allows our behavioral health program to be here. So first, thank you to all of you. And then I want to remind you that this session is being recorded for later distribution. You may always go to our Be Well Texas YouTube page and review the content of this class. If you're joining via phone, please send us an email letting us know that you were here so we can associate your phone numbers with your names. We know that when you join via phone, you just cannot use up the chat, but we still would like to record your attendance, especially if you're seeking CEs or if you're part of our providers network here at Be Well Texas. And in this session, I know many of you are familiar with the structure of this class, but just as a reminder, this is a 1 hour Zoom class. We will listen to a 25 minutes didactic presentation, and we're opening the floor for questions. And after that, we're moving to our case discussion. And this is where we really encourage your participation. Remember, one of the goals of this class is to support our case presenter and give them strategies, ideas on how to manage the case. So please don't be shy. Just raise your hands and wait until you're called, and we'll get to all of you. Just one small warning. We always have to make this observation. No PHI during the discussion, the portion case of the session of the discussion. And that goes specifically to our case presenter today or anyone in the call who may know the person in question. So no names, no addresses, relationships, or anything that could help us identify the person. But besides that, everything is fair game and we're going to have a great session. So let's start with some introductions. Didi from California, how are you today?
Good morning, everybody. I'm Denis Stout, and I am in private practice here in California with Denis Stout Consulting. I'm also an adjunct associate professor at St. Mary's College in Moraga, California, where I am in the forensic and counseling psychology department, teaching the next generation of therapists a little bit about harm reduction.
Oh, thank you. Great. Dr. Aguilar, would you introduce yourself, please?
Hello, everyone. My name is Clarissa Aguilar. I am a clinical psychologist, and I work at the Center for Healthcare Services as the Director of Psychology and Training in our integrated primary care clinics, where we serve patients with severe mental illness together with their chronic medical conditions, including substance use treatment and comprehensive mental health services.
Welcome, Dr. Aguilar. And our case presenter of the day, Miriam Pina. Would you introduce yourself, please?
Yes. Hi, everyone. I'm Miriam Pina. I work for the Be Well Clinic. I'm an LPC here and happy to be here today.
Welcome, Miriam. And Dr. Antoine, we can introduce Dr. Antoine. He's going to be our speaker today. Dr. Antoine, if you could briefly introduce yourself, and then you can take it away with your presentation.
All right, thanks so much. Good to be here today. My name is Dr. Denis Antoine, logging in from Baltimore today, where I'm a faculty member at Johns Hopkins University, and I'm director of two of the treatment programs there for persons with substance use disorders and other mental health issues. So happy to be here today, and I'll share my screen just so we can get into the presentation. This is actually a continuation of a talk that I think went on in January of this year, where we had a conversation about different cultural elements of administering care. And the extension today is about bridging cultural gaps in healthcare strategies for effective clinical practice. And the goal, beyond just the disclosures that we have, is to try to identify and create empathy towards different backgrounds and how they maybe influence beliefs and other treatment preferences, and then try to develop some strategies that could be effective to build trust from persons from various backgrounds, whether it's cultural or other types, and then find and really talk about how that might impact outcomes as well. This could be a 5 hour talk, 10 hour talk, really a workshop of its own, but I'll do my best to really dive into the principles underlying how we can get to this point. And to start with just this structured way of looking at it, there's culture at an individual level. It could be these types of categories. Certainly could be more than this, but often you see a list of the different categories a person might have in terms of the different cultural levels individually. Beyond that, though, there's another way to look it through, meaning that there could be an obligation, if you will, on the part of the practitioners to understand how those cultural factors, whatever they may be, might play a role in supporting recovery. So not just saying a yes, no to the box, but saying, hey, how does this play a role? And if you're looking at a CARF accreditation, they start thinking about strengths, needs, abilities, preferences, things of those nature, and that is part of culture as well. But what is said sometimes in the literature, as this quote says, is that that should be brought into the process of treatment planning. And it's important that the counselor or the health practitioner understands the roles of these cultural factors when a person's getting to what we call cultural competence. Now, how do we do that? There are different ways. One, you could always think about the treatment plan at multiple levels. So it could be the individual level factor, but also thinking about a clinical program level to see if there are things that are happening as a clinic that account for these factors. But then also thinking about barriers organizationally or administratively that might count for that as well. And this is a slide I brought up last time because these types of levels go into what we're talking about more and more, which are the social determinants of health. The educational, economic, social context, healthcare access, and also the neighborhood social environment. These are more and more things that are going to be talked about and required of treatment plans. Just had my second Joint Commission accreditation visit this past month, and they're really talking about this being required in the treatment plan itself. So you'll probably see this wheel more and more to come. And beyond that, it's a question of what does the practitioner do? How do we account for that? How do you start this conversation? And I always use the slide in many of my talks now. This is Bob Ross, a painter. And I say to many of the individuals that come in for treatment with me, I'm not a painter. I cannot paint, which is true. But I do want to paint a story or a picture of your life and how it's been. And I'll start with a blank canvas, but ultimately I need to paint a rich picture and it will take time. What I've started to tell people over time, though, is one, there are going to be portions that they want to focus on, and I need to make sure I jump around and get the big picture, which might include cultural elements. But what I've also started to tell people is I might not have the same look as Bob Ross, and that might not reflect the look of the person who's coming in to get their paint or their picture painted. So there needs to be some type of acknowledgement that I might not paint the same picture that they would, or that there may be elements that I'm missing along the way, and make sure they just tell me, hey, you missed a spot, which is okay, and leaving room for that. And it goes to portions of what I have on here, which are the aspects of cultural humility, which are important to recognize because you have to be able to reflect that back and respect the person's background, respect that you might have picked the wrong color on the painting, and you might have to change it a little bit. Make sure it's relevant to what they feel, and make sure it's understanding that they've gone through a lot and have been resilient through a lot of experiences to get to this point of telling you their story. So that is a really key element to cultural humility and just something to keep in the back of one's mind. However, from a more structured approach, there are some elements that are important as well. One thing to consider is motivational interviewing, which is also called motivational enhancement therapy. And it's really brought together from decades of research that's culminated in this more structured approach where you're led to a guiding style of communication. And I know many health providers on this call are familiar with it, but just to review, it's supposed to be a balance between the following and the directing, or listening to a person, but also giving advice. And the suggestion is always that you're listening at least twice as much as you're giving advice and trying not to steer the whole conversation. But it's always a reminder. Even as I'm painting those paintings, if you will, here in the story, I'm trying to make sure that a person is, telling as much as they can, and I try to keep the conversation going with those open-ended questions to draw out the meaning that they want to give, and not just paint my own picture of what I think it is. Make sure I understand what they feel is important is captured, and make sure I understand, what their capacities for change and reflect that back to. But similar to cultural humility, which it sounds like motivational enhancement therapy is a precursor to that cultural humility, it was always brought up that respectfulness and a curiosity about that person's being is important, not just going in with your own thoughts. So that's something that is at the core of MI. And this mnemonic is always one I like to refer to as well as one of the core ones. There are multiple mnemonics such as ORs and other pieces, but I like to use this one because it's something that comes up a lot in terms of when having that conversation or when being part of the interaction. You want to resist as much as possible telling the person what to do or directing them, which will increase your ability to understand their values, not just understand what they might have as a primary complaint, so to speak, but really understand the values and needs and strengths and potential barriers that they may be having to changing their situation or helping change their situation. And you have to do that through listening. Again, listening more than you give that direction. And the last where I know it can be difficult at times, and they have in power, that's what they've used to having, but really having an engagement, if you will. That's the way I like to use that a little bit more, engaging the person in a way where you can accompany them through their journey towards seeking their goals and helping out wherever you can to identify techniques and overcome those barriers. So I hope in time that someone could modify that last word in the mnemonic that's often used, but this is a common word that comes through. And again, coming back to this list of individual cultural items, this list could go longer, and it's typically structured in this way to say, all right, what's the age, what's the ethnicity, gender, sexuality, usually categorical in that way, and they don't often overlap. And you are allowed to take one at a time. But over and over, you're starting to hear more a term that looks at this in a different way, and that's intersectionality, which is described often as the interconnection of those different categorizations, so that you understand how they overlap and they may cause some type of discrimination or disadvantage or power overlap or some gap that needs to be looked at in a different way than just separate categories. So instead of that list that I showed you before, the categories could actually look like this, in that they're overlapping and you have to really know where a person falls. And you could almost see yourself spinning the three different wheels and it coming up in different ways itself. So it's a very complex way of looking at it, and it takes time. Which again, going back to that Bob Ross analogy, I tell a person sometimes that first session is just about the primer coat. You're going to need to get more and more and more layers of that to get the full picture and get it as rich as what you see here. But intersectionality could be a lot of different things. Culture could be a lot of different things as well. It's not just about the culture, the gender. It's much more than that, and it will sometimes take time to gain comfort from that person to tell you the whole story. To do that, there are different ways of going about that approach as well. We talked about MI, or motivational enhancement therapy, which I think is an important underlying principle. But one that's coming around more and more to broach these topics is something called broaching. This is a therapy technique that's been around for a little while now, but it is trying to get to the conversation of how do you make sure that intersectionality is permissible in the therapeutic conversation, making sure that there's room for that. The things that might be less comfortable or really not necessarily standardly asked, making sure a person is okay to say those things. And it's the broaching technique allows persons to explore what they're feeling, and also acknowledge the limitations of the person who is the provider, saying, hey, look, I'm not in that same space, but communication of whatever you're feeling is okay. And it avoids reducing the individual to just those categories, as I mentioned before. It says, hey, look, anything we missed, anything I missed along the way. And I'll leave people to read this portion on their own. I often don't read slides, but I found it important to just give an example of what that could look like. I try to say it from the Bob Ross approach, saying, hey, look, did I miss anything on there? But I also start to say, look, I recognize I'm not from the same background as you. And this example could be racial, ethnic, but you could change any type of cultural factor and say the same thing. And that allows a person to say, I know there may be times when I can't fully appreciate where you are, expressing that empathy, but I just want to know that I'm open to you talking about these topics whenever you feel they're relevant. Keeps the door open and does pull from the MI approaches and other types of approaches. But what has been shown is there's a continuum to how people usually leave the door open to these type of broaching comments. And that comes through in the next slide, where you see this continuum from top to bottom. Some individuals have been shown to be of the avoidance style, where you just don't see them talk about those cultural factors at all. And that can be tough, that can be difficult, and it may not allow for full conversation. After that, you could also see an isolating style where there might be, one type of topic or one type of factor where they might pick out and really hone in on that, but the rest, not so much. And that could also be a bit limiting. And then you see a little bit more, which would be, well, we covered a few things, but it might still not fully match with the intersectionality of what a person is going with. And that, is getting in the right direction. And it probably takes practice to say, well, is there anything I'm missing? I want to make sure you're more comfortable. And even, wherever a person is, there's no issue with being anywhere on this continuum. It's just being aware. As you get into the more integrated and congruent phase of this broaching, that's when a person's really pulling in all the items into the conversation. But what's the difference between that and infusing? Infusing is really, it's an effortful approach where you're taking on, but also putting more ideas out there that can allow a person to really problem solve into that space. And that takes probably a lot of work because if one, like myself, wouldn't be a part of another person's culture, you'd have to do more than just empathize or sympathize. You have to be actively involved, and it does take work. But all to show that there's a continuum of how a person could broach and integrate those issues into a person's care and find other ways that might not be regular for a person in their own shoes. So finally, I'll just end with the fact that doing all this is all still geared towards looking towards those social determinants of health and identifying how we can eliminate health disparities. That's the goal of why this is done. It's not just looking at culture, but really understanding what are those barriers that increase the burden of disease, injury, violence, and look for opportunities to achieve optimal health for all persons. But if you're not looking at all the different aspects of who a person is, and it's difficult to really achieve this ultimate goal of health disparities resolution. So that's why I feel it's important. And again, this could be a whole workshop, but the whole goal here is to begin the conversation with some practical strategies of how to continue that conversation with the individual walking in the door. And I think having heard some snippets of today's case, I think it's going to be interesting how that overlays into that as well. So thank you very much, and I'll see if there are any questions.
Thank you, Dr. Antoine. So we're opening the floor right now for some questions. I think you're muted.
Oh, sorry.
Now you're speaking. No, now you're fine. Thank you.
Okay. I have some questions about this approach to motivational interviewing. I consider the scenario that, if somebody's not very motivated, ambivalent, and sort of discouraged, that would be a case where motivational interviewing, you're bringing out the motivation in them, perhaps, would make sense to me. But if the patient's motivation is to get the clinician to prescribe, Norco 325/10 6 times a day, preferably a 30-day supply, then maybe motivational interviewing wouldn't really make a whole lot of sense. I think that, personally, I feel like motivational interviewing is primarily designed to help patients explore and resolve ambivalence. When, you can express empathy and develop a discrepancy between goals and current behavior, rolling resistance also works. But when you do have this completely divergent motivation, where a patient's primary motivation is to obtain a controlled substance, and that's obviously one of the more stressful things that a clinician deals with, typically motivational interviewing doesn't really align well with that situation. For example, number one, expressing empathy. The clinician can seek to understand the patient's perspective and reasons for wanting the medication without necessarily agreeing to prescribe it. Okay, that makes sense. Exploring ambivalence, even if the patient seems single-minded about obtaining a medication, there may be underlying concerns. Okay, yeah, you could do that. But ultimately, this rolls into a misalignment of goals where the clinician has a different goal than what the patient does, and there's going to be a mixed message at some point.
I, yeah, I think this is a great point. What Carlo Di Clemency told me is he never used the term motivational interviewing, and I usually go with motivational enhancement, and it's really more so motivational moments. And so the goal that I would see in this situation would be what aspect is utilizable in a person like that as a psychiatrist versus a primary care provider. I would just want to avoid the writing reflex, and come to an understanding and see what could be done. And if that person is, as I joke sometimes, in the anti-contemplative stage, then you really can't do too much. But that is a point of just resisting that writing reflex, accepting where they are, and hopefully they come back and instead of not coming back at all, and we know what that means. And so if that's the goal and that's the outcome, I'm okay with that. But I agree with you that we are not there to change a person and who they are. We're not going to change that goal. But you want them to come back so you can help them eventually move to the contemplative or action phase. And if it means nothing that day, I agree with you, then that's where that motivational moment could be.
Thank you, Dr. Antoine. Comments, questions from anyone from our group? I find it interesting, Dr. Antoine, that you leave that slide about health disparities to the end. It's kind of in the order that you would think that one thing leads the other. How sometimes that lack of empathy with people who have different cultural backgrounds can lead to those disparities. Can you speak a little bit more about that in your experience, in your own practice?
Yeah, definitely. Just in my own practice, and I'm a psychiatrist, addiction medicine certified, so I see a little bit of, I think the reason I chose psychiatry over internal medicine is not to say I don't like both. I actually love both of them, but I always found that the person's coming back to the office or the emergency room had a deeper story that prevented them from accessing the ultimate solution. And sometimes I also found that individuals who were coming back in didn't have their full story heard. And that if they were heard, it might have actually led to a different outcome in accessing what was going on. All right, my phone's off. So you're not going to get that text about the appointment. So we shouldn't have canceled that appointment. Things like that, that even happened to me along the way growing up, really stuck with me and are social determinants of health. So how you get to what's the barrier might, be an argument in the moment, but it might lead to something extra that could make sure that person shows up on time.
Thank you. Didi.
Hi. So talking about motivational interviewing, which of course I'm a little sensitive to since that's my area of expertise and have been in Mint for 25 years now. We are on the fourth edition, which the subtitle is helping people to change and grow. So what we're seeing are more areas where motivational interviewing can be utilized. That it's not just about resolving ambivalence. In fact, sadly, to many of us, we don't even talk about ambivalence in a lot of the fourth edition. And again, I'm not one of those. I do talk about ambivalence, and I do like the rule acronym and some other ones. But the point of MI, and there's a lot of different ways of doing it. I call it motivational conversations. And Bill and I had that conversation, forgive me, at one point, because I said, I'm not comfortable with this motivational interviewing thing. It feels like I'm shoving a microphone in somebody's face. My background's in radio, so that's what I was doing. And he said, in honesty, If I were to do it again, I'd probably call it motivational conversations. And I'm not doing it again. And I went, okay, but it kind of gave me permission, if you will, to go ahead and keep doing that. And I think of it as the art of possibilities. It's where we can maybe get to with a patient or a client that we would not normally get to if we're just sticking to our agenda. And that's the way I was trained in the hospital. We have an agenda. Here it is. There you go. And what I've learned from MI all these years later is I got to let go of that agenda. It doesn't mean that I can't have some things that maybe I even need to talk to a client or a patient about. Absolutely. Sometimes in various roles. And then I can just say, would it be okay if I shared some information with you? Or I have a couple of concerns. Could I share those with you? And I never have had anyone say no. They're in your office for a reason. They want our expertise. What they don't want is kind of to get bullied about whatever they're doing is wrong or they need to change everything. Also, just an aside, as a person who is on opiates, who is a chronic pain patient and technically and legally disabled, here I sit this morning. Opiates are not bad, and some of us really need them. I know there's a lot of controversy around that right now. And I just want to say, I'd encourage you to really listen to your patient, and maybe you can compromise on how much or, how often that person is taking it. One of the things that I make sure when I talk to folks around it is say, the medication needs to help you to do other things. That can't be the only thing that you're doing for your health and for your pain. There has to be a full plethora as much as you can capably do. So whether that's, getting support from other people, if it's attending church, if it's going for long walks or hikes in the woods, all of these different things, looking at food, especially, that can make a huge difference to how I feel. And that's part of my background too. So thanks. I've been talking for quite a bit and I appreciate you listening. Thanks, Ed.
Okay.
Good job.
Thank you, Didi. Oh, that was great. I love it. Motivational conversations then. Okay. Anyone else? Any questions, comments? We're opening the
I have
floor.
another question,
Sure.
just based on what Didi was saying. So since you have a lot of experience with this, imagine that you are in an emergency room and there's somebody who's complaining of severe back pain, or the pain is, beyond what they can imagine. I mean, you've been there. What in a nutshell would you say about motivational interviewing or conversation in that case?
Yeah, that's a great question. Thanks. I think it would be, what would you want in this moment? And start from there, not saying just because I've asked you what you want. And sometimes I'll say to my own clients, just because I've asked you doesn't mean I can give it to you. But that's a good place to start.
Mhm.
And then we can work from there. Yeah.
Right, but they're not going to say, I don't know, they're not, they're gaming you.
Well,
and you've got to
okay,
play
I'm going to
along with that.
invite you to suspend your disbelief there for a moment. They may be, but they may also not be. There's just as good of a chance that they're not as there are. If I could, let me offer you something that I did after I got trained in MI. And I've only worked in addiction or addictive behaviors for almost 40 years. That's been my field. And I remember going back to my office one day and deciding that I was going to act as if all of my patients, I was at the hospital then, were telling me the truth. Absolutely the truth. What would happen? And what I discovered was suddenly they were telling me the truth. And after a few weeks, I had to stop and kind of think about it and said, what changed? They haven't changed any. So clearly it was me. There was something about the way I was being with them. I was being more open to listening to what they were telling me and giving them space to get below that, to get under what they're just saying with their words, and really deeply listening to what their concerns were. Now, I can appreciate in an ED situation that may be difficult. You may not have that time to have that lengthy conversation. So this is what I call MI on the fly. And, so what we do is we try to figure out and open the conversation, right? So ask, what is it that you would like us to do for you today? It sounds like you're in an awful lot of pain. How can we help you? And find out. And if somebody says, well, I want a shot of Demerol, or I want to leave here with, 25 Norco 32510s. Okay, I get it. And it would seem that something along those lines would be understandable. How about if we start with whatever you want to give them? And then instead of I appreciate you'd like to have 25 when you leave. How about if we give you 5 or 10? And then let's see how you are. I want you to check back in with your primary, find out who the primary is, make sure all that's connected, and go from there so that you're not fighting with that patient in that moment, because all that does also is increase. When we increase our stress as pain patients, it increases our pain. That's a physiological thing. So the more I can relax, then I can also give you a better estimation of what my pain really is in that moment. Does that help at all?
Yeah, I think that I approach it a little bit differently.
Yeah.
Basically, what I do is I ask them, okay, your back hurt. Has it ever hurt like this before? Is it more than usual? What has changed? When did it start? How was it treated? Did that work? Did it not work? So it's more going to what the history was, and
Yeah.
I can ask
Oh,
them.
Absolutely. I was assuming you didn't have that much time.
Well, I mean,
Sorry.
I mean, how
Yeah.
long does it really take to ask someone when did
Yeah.
their pain start and what worked and what didn't?
Yeah. Yeah, absolutely. And that would be a logical and a good thing to ask, even with any kind of medication, right? The first thing that most doctors ask me is, what have you tried before? If you've had this before, what helped you before? That's a good place to start, whether it's a pain medication or an antidepressant or an antibiotic, right? It doesn't matter. That's a good starting point. Yeah, absolutely. So it sounds like you're doing a lot of, the right things, if you will.
Oh yeah, I mean, I
Yeah.
have no hesitation of prescribing opioids in a appropriate situation, maybe not for a very long duration of
Yeah.
time, maybe with a certain type of follow-up, or
Mhm.
so, and also try to form a therapeutic alliance maybe on some areas where there isn't such a discrepancy. Maybe they haven't had an x-ray of their back, and that's something we can do.
That's right. Yep, that's a good point.
Can I say also that, like, really, if somebody is seeking that, they're seeking those medications for a reason, because they need them, right? And if they don't get them from you, they're going to get them somewhere, and that is likely to be on the streets where it's not a safe supply and where it will kill them. So, really, like, I always say that it's better to give somebody a safe supply.
Well, that may be buprenorphine, if they're not, if they're on heroin or fentanyl, it's going to be tricky. You're not going to be just able to just give them fentanyl or heroin or that kind of thing. Or if they say, well, the only thing that works is Dilaudid, you're not going to be able to give them necessarily.
Well, I'll give an analogy from the psych side, and I know we're taking the time up very nicely right now, but on the psychiatry side, there are medications that help with thoughts of suicide, but they're also harmful in overdose. Lithium is the main one I think of. Great for that, but harmful. And what we do is we just give a limited amount. We don't give a 2-month supply, 3-month supply. We'll say, I'll give you some for a week. One person I did every other day, and they would come back. So that's just an option.
Thank you, Dr. Antoine. That's great. And this is a very interesting conversation, and I think we will continue it as we move to the case discussion, because there are some elements of the didactics today in our case. In the meantime, I think we can briefly go through our announcements, and whenever we are ready with those, Taylor. Thank you. The Center for Substance Use Training and Telementoring CSTAT offers technical assistance. And if you need technical assistance from us, all you have to do is go to our webpage. We are sharing that page with you in our chat right now. And there is a TA form. Someone will get back with you in approximately 3 days. It's a free service. We're more than happy to help you or your organization. So please use this resource. Is really something that one of the reasons why we're here at CSTAT. Again, the page is there on the website, on the chat, and there is a form specifically for your type of technical assistance. Next, please. If you're claiming CUs today, it's very easy. All you have to do is answer the post-session survey. We're sharing that link here, and then we're sending it after this class along with the didactic materials. Of course, if you answer the survey here, you don't need to answer it again. And when you find the question, are you applying for CU credits for today's ECHA session? Just answer yes. You should be receiving your certificate of attendance in approximately 2 or 3 weeks. Thank you. Next. And we have this study here at Be Well, Texas. We have had it for a while, and we still have it. If you want to participate, just please contact us. We're sharing the information on the chat. And very briefly, we have here Jessica, and I know she's going to tell us very briefly what to do. Jessica, go ahead.
Yes, thank you so much. Yes, as Andrea said, this study is still going on. It's for people that have recently started buprenorphine or Suboxone treatment. It is a virtual study, so it takes place entirely over Zoom and over the phone. We'll be recruiting for the next year or so. Our contact info is here along with our QR code. We're happy to speak to anyone who is interested. So please, we're just getting the word out. Thank you so much.
Thank you, Jessica. Next slide, please. We're always looking for case presenters here at CSTAT. So if you are ready and willing to discuss a case with us, please send an email at cstat@utesca.edu. Next slide. And next month, we are going to have a discussion on radical love, utilizing harm reduction psychotherapy and substance use disorder treatment. Please don't miss it. That's Friday, September the 27th. Thank you. And now I think, Miriam, if you're ready, we can start sharing your case. And if you could briefly walk us through the case. Thank you.
Sure. Okay.
Perfect. Thank you.
Thank you. So this individual is a 55-year-old male, Hispanic, heterosexual. First of all, I want to say that they've been an absolutely pleasure to work with, and they attend counseling therapy weekly. So what I'm bringing to you guys is really, I've been working a lot with them on motivational conversations, empowerment. I love that, Dee, thank you so much. But really it's just continuing to empower this patient on their personal goals, really helping them build that self-esteem to move forward. So as far as abstinence goes, they have been abstinent for 8 months. They came to Be Well after receiving treatment in a residential setting. Their goals right now are just continuing that abstinence, increasing confidence, reducing anxiety and depressive symptoms, that continued care plan, continuing to implement recovery skills. And as far as personal goals, they would love to become a recovery coach, as well as get their own place and get their own vehicle. So as far as existing supports, they have 5 children, which I should add, one of their initial goals was to increase communication, enhance the relationships with their children, which they've done phenomenal with. But the children are very supportive to the patient. They actually live with they're all adults, their grown daughter and then their son. And also patient is familiar with some resources. They have volunteered before with organizations. Also mentioning they do work full-time. And some strategies that I have worked with them on is definitely the MET, motivational interviewing, motivational enhancement, CBT. They really like that. They really like working on how to restructure their cognitions, and then working on that boundary setting. And so the substance of choice that they sought treatment for really was heroin. That was their primary substance. And I would say secondary to that was alcohol, and the other substance that they actually quit on their own is nicotine. Just one day told me, hey, I stopped smoking cigarettes. I have a cigar. I puff, but I don't inhale. So they, yeah. But so they worked really hard on the abstinence goals. That was a lot of our initial sessions, was working on that relapse prevention plan, those recovery skills. So that was a lot of the initial work that we did together. Yeah, so this is just telling like what they had been in substance treatment before, had relapse, came back. They are on Suboxone, and as well as gabapentin and Wellbutrin.
Thank you, Miriam. What's your specifically concerns or questions that you have for our hub and for our learners today?
Yeah, so this is where it gets to the trauma. So much of their trauma and much of our initial work and continued work revolves around their wife. They were their partner that they would use with. Their wife has untreated schizophrenia and continues to use to this day. And they will make frequent visits to where the patient resides. And it's just really disruptive, to the patient. I've worked so much with them on that emotional regulation and how to handle those situations, but it just continues to be just something that, an external factor that they cannot control, or that they're right now, them coming around. Where they could manage that is moving out on their own, but that's been a sticking place as far as I've done a lot of change plan worksheets with them as far as their readiness to do that. We talked about sober living, and they've considered it. We kind of feel like that's a step down, and just really that next step of that independence. And so that's a lot of, I would say, that trauma, the triggering, and one of their children was also diagnosed with schizophrenia, and so that was another re-triggering moment for them, and just processing that. But they really, I think the self-esteem is still just a huge thing for us to work on. They see their progress. They've worked on just restructuring their thoughts when they go to a place of, oh, it's not a big deal, but they're able to bring it back and say, you know what, it is a big deal that I've been in recovery still. So I'm so proud of them for that. And they are able to recognize those moments. But the self-esteem is still a struggle. And so I guess where I really wanted to bring this is how to help this individual when they are in an environment that is still triggering to them. But they continue again to do well with making the choice not to use. So that's really what I'm bringing to you guys. Yeah, and as far as strategies, like I mentioned, a lot of motivational enhancement, motivational interviewing, CBT. I've done some DBT. I've done some grief and loss in relation to that was specifically in relation to the wife, that ending their relationship. And so those are some of the strategies that
Thank you.
I've tried.
Thank you so much, Miriam.
Absolutely.
So we're opening the floor now for questions, ideas, insights from our group. Dr. Lubner.
It's a very interesting case, and I think a very relevant case that I think any of us can relate to. You can take a lot of pride in the progress this person has made, and that there seems like they're getting better, whether it's slowly or not. And so some of this will get better, could potentially get better with time of just staying the course. So sometimes I hear the expression, your job is to entertain the patient while they get better. So there's some of that. But then on the flip side of it, what can we actually do? Um, I looked at their medication regimen, and Dr. Antoine could probably comment on this. It doesn't seem to be optimized for PTSD as far as I know, but maybe I'm wrong. And then so if they're open to that, that could be something that could help. And maybe a PTSD specific type counseling. I don't know all the acronyms. I just know my patients get excited. They tell me all about
CPT.
it.
Yeah,
Yes.
it's a great point, Dr. Lugner. I was going to say, one, Miriam, you've done a great job with getting this person to where they are, and I think that's the key piece. The opioid reduction, and I was even struck by the tobacco reduction, which tobacco is actually the
Absolutely.
most addictive nicotine. That is
Yep.
the most addictive substance pound for pound, and to go from one pack to nothing, I would bet there's some remnants there. The other thing about tobacco and nicotine is that it actually does hit upon the dopamine, which would enhance the PTSD symptoms. So I wouldn't downplay the role of nicotine and what's going on there. And vaping is more frequent, and I would just ask if that's part of the picture. To your question, Dr. Luckner, I would say after focusing on that nicotine, it could be whether the Wellbutrin could enhance some of that PTSD symptoms, which could occur, or there could be an addition of another medication. But I think getting more information is probably a good idea. Didi, I see you over there as well.
Didi.
Yeah, well done, Miriam. And your client really deserves, huge props, huh?
Absolutely.
For how much work that he's done. Wow. So I'm curious about two things. One, you mentioned a sober living environment of some kind. And because they're on MAT, do you have any places that will accept him? Here, I've got to tell you, in the Bay Area, we
Yeah.
don't.
Right.
So,
Yeah. So, well, first of all, to answer the question, they do not vape. Back to your question, they are, I would say, ambivalent towards medications, not wanting to be on a lot of medications. As far as their PTSD diagnosis too, it's right on the cusp. I would probably see most, like maybe a little below the cusp when I've done assessments, but I would say I probably most see it in their hypervigilance of is she around me? Is someone there, following me? But Didi, yes, there are sober livings, but again, and I think it was Ralph that said this or someone said this, but going back to like where I feel like we're hitting a point is what they want as far as that living arrangement, because a lot of the moves that they've made have relied on the daughter. And and that's what we've talked about. Are you waiting for the daughter to move out or to close lease first before you make that move? Because again, that sober living, they haven't, they were going to talk to someone about it, but never did. And just,
so it seems they're not really interested.
yeah, I think they're feeling like that's the right thing, but that's not the thing they want. And they really mentioned they had to kind of process through that, like feeling like it was a step down for them, but then they came back to a place like, maybe it's not a step down. Maybe I could do it just for a little bit. And so it's gone back and forth as far as the next steps with independent living.
That's great. And the other thing about the PTSD that I would be looking at, I think, are some somatic pieces to this. And again, kind of back to that, what are they doing about, are they getting, I know this sounds kind of silly and woo-woo, so forgive me, I know I'm in California, but are they getting out in nature? Are they doing something? Sometimes I'll just call it body movement, because the E word, exercise, freaks people out, right? So, so what are you doing that's kind of getting your natural endorphins up? It can help with pain relief. It can help, you feel better, those kinds of things. And see if there's some more natural ways of helping with the PTSD if it's not severe, especially if he's kind of on that cusp. And then looking at whether he'd be interested in some sort of, it can be anything from singing and dancing and acting, painting, to borrow Bob Ross, to the other side, doing something like I'm certified in brain spotting, which is sort of a piece off of EMDR. A lot of people find relief in EMDR or in brain spotting, one of those two. Somatic experiencing is another one. Peter Levine is out there. So there's a lot of sort of body-based things
Absolutely.
that can be done that can be also creative and tap into that piece as well.
Yeah, definitely doesn't sound woo at all. They actually do enjoy walking and are near a park. And so that does,
Great.
yeah.
Okay.
Yeah, one thing I just wanted to add in specifically about the trauma and the treatment of substance use is Seeking Safety is a curriculum that I really like. And given some of the relationship issues that are going on, I think it might be helpful to consider that or to find practitioners. Right? Maybe you're familiar yourself, Miriam, with the Seeking Safety evidence-based curriculum. It's an integrated treatment that treats trauma and substance use simultaneously, and it has an emphasis on, safety in relationships, boundaries, things like that. And if you've ever been through the training, you know that they kind of use quotes as kind of their starting pieces to their groups and sessions, and it can be really, really helpful. And just thinking about who he is, potentially that might be a good fit for him. But I think it is hard. It's a hard curriculum to find. You have to find somebody trained and has been certified in Seeking Safety.
Oh,
So I just
thank you
wanted
for
to
that. Yeah,
mention that.
thank you. I'll look into
You're
that.
welcome. Yeah.
And one of the things that we were discussing, Marianne, during the pre-session, is he currently, I mean, he's not living with his wife anymore. He's living with his daughter and son, correct? So he's not exposed to that relationship at the moment, or is he?
He is exposed in the fact that she comes around, and not she's not permanently residing there, but there will be a couple days staying, a couple days, then leaving, periods of leaving, coming, going. And so, mhm. Mhm. Yeah. Well,
So
thank
I
you.
always advocate for peer services. Obviously, that's what I do. That can be really helpful to, kind of bring somebody in that's been in similar situations and things like that. Just to help guide them.
Yeah. I have definitely they have refused. They aren't interested in that, but they do know a lot of people and from their volunteer experience in recovery. But yeah, I've tried and I've tried several times to put that in to see if it would be an additional support.
Has he expressed, Miriam, why? What is the reason for his reluctance to seek services from peer services recovery?
Yeah, I think there's just a little bit. I think just really some, I would say, isolation in that area, and also hesitation even in past meetings that were attended, recovery meetings, that they would gravitate towards people that were using still, and then frolic, engage in behaviors with them. And so I think that's some of their concern. Mm-hmm.
I did also want to say real quick that back to the recovery housing, there is for individuals who are on MAT, there's a program that I think I know it's UT Health Houston, sorry, runs, that is Project Homes, and it's actually free for somebody to live they have recovery houses across Texas, and it's free for a year for them, and it provides a lot of supports, but only for people who are newly on medications, so like MAT of some sort. Just so you're aware.
Okay. Thanks. Thank you guys so much.
I would also say that, a lot of times these opportunities to change the therapy or to add something like peer support come when the time is right. Some of it is just kind of keeping them stable, as stable as as they are right now. And then when there is an opportunity, let's say that the estranged wife is hospitalized or arrested, then during that time, maybe you can change the locks. I don't know, but talk about peer therapy. Maybe they'd be more open to it. You just have, I think that's what I do a lot of times is just keep the patient as stable as I can. And then when there is an opportunity, maybe they're really struggling with something, to say, I need to do something else, and then bring that up, and just being patient and realize that time's going to come. And sometimes, the problem goes away on its own. The strange wife not be in a group home or something. I don't know, but a lot of times it's just about being patient and looking for opportunities.
Thank you for that. Yeah, I definitely have seen differences in their demeanor when that person is away versus back in the picture, obviously. Yeah. So thank you so much.
It also cannot depend on the peer specialist. I know that like when I start meeting with people, half the time I will just go out walking with people. Like it's not really approached as like I'm gonna help you in your recovery. It's more like hey, let's go get outside and go do something, right? I'm bored. Let's do something today. Let's go shopping, something like that. So that can be helpful too.
Thank you. Great idea. Thank you. Let's see. Other ideas from our community learners.
Just to jump on that, Lindsay, there is something called walking therapy.
Oh, there you go.
Yeah. And it was a old client of mine that did that one day. I lived by the beach, and she said, could we do our session on the beach and walk?
Wow.
Okay. Okay with me. I got my exercise in for the day. And then I kind of looked it up, and sure enough, there was actually a sort of a therapeutic model for that.
Right. That's great. Good to know.
I actually have a follow-on question. I have a lot of trouble getting my patients into peer support. And sort of a common thing I see is the person's afraid, first of all, they may not feel comfortable in groups of people, or, they're embarrassed. And what are some things that we can work with on our patients that would get them into peer support, I guess is the question.
Actually, I'll let Lindsay, you go ahead.
Let's say so. Really, it helps if it's one-on-one peer support. I always start out with it's free, first of all, because it's always a selling point, right? It's usually you can find it for free most anywhere. And that it's really just about having somebody to, be around and bounce ideas off of. That it's not like ideas that may have nothing to do with substance use or may have nothing to do with recovery, right? It could be about anything. If somebody likes to paint, it could be somebody to paint with. It could be somebody to find good books and read with. It could be anything. So kind of approaching it from less of a clinical, perspective, and just it's somebody to just be a friend with.
Thank you.
Go ahead.
No, go ahead, Dr.
Antoine. I was going to say, I think you're right, Lindsay. It's different vantage points that could be helpful for. And I would just make sure they're exploring different spaces to be in group activities that are safe as well. That could enhance that. Doesn't have to be clinical. Doesn't have to be. It could be a NAMI where you can get support groups there, but it also could be a safe, place where there's going to be a good activity going on. And I just, the biggest factor that's supportive of any type of help or recovery, whether it's mental health, substance use, is social support. So anything that can enhance that individually or group would be good. And sometimes people who struggle in those group settings may have an additional psychiatric issue that's underneath that may need a little bit more work as well.
Thank you, Doctor.
I had a client that decided that they wanted to get healthier in a lot of different ways. And one of them was, sort of in their body, if you will, and got a strength trainer. It got him to the gym. And I was like, yes, I don't care what kind of support. Yeah, find another place, another activity that's also healthy. And it wound up being really helpful for him in his mental health as well as in his substance use.
Thank you, Didi. And just because for the sake of time, Dr. Aguilar, if you could briefly give us a summary of the session, specifically the case and some recommendations. Thank you.
Yes, thank you so much, Miriam, for bringing this case to our discussion here today. What we heard today was really this nice conglomeration of factors from Dr. Antoine's presentation. His emphasis actually on intersectionality and the importance of broaching to try to help individuals like your specific patient who is probably needing to feel that he is in a safe space. There's a cultural element here as a Latino male, being a victim, and also really trying to stay in recovery and in treatment. So I feel like we've talked about several different opportunities like peer support services, recovery support services, and how those might be framed in a way that would be more acceptable for him from a cultural standpoint, perhaps that might be a factor operating. But also to help him capitalize on some of the gains and strengths that he also has. You know, I mentioned seeking safety. There's a lot of talk about the basis of motivational interviewing as well or motivational conversations as well. So perhaps those are things that you can continue to work with and apply. Thank you so much for your time. I know we're out of time now, but hopefully that's helpful to everyone.
Of course it is. Thank you. And we want to thank again our speaker today, Dr. Denis Antoine, and our case presenter, Miriam Pina from BUL, Texas. Great case. Remember, next month, we'll meet you here in this space, and please do not forget to answer your post-session survey. Thank you to all of you, and we'll see you next month. Bye.